Hello, in this video we'll be covering my notes on discharge and follow-up care. So when we have a baby born, whether it's going to go to NICU, whether it's just going to go well baby, stay with mom and get sent home, they have a couple requirements that need to be met. And if you ever have baby in the NICU, this is what the parents are going to ask you. They say, when can I go home? When can I expect the baby to come home? And the best answer is I don't know, but there are a couple things that can get you out of that question a little bit. So the infant has a couple of things that they need to make sure that they can do. So first up with them, they have to show us that they can maintain their temperature. So they're not going to get cold. They can just be able to maintain themselves. It's a little thermometer in just their regular clothes, so they're not going to get cold while they're at home or just to rest. Next up, we have feeding. We need to make sure that they can safely feed without any drops in their oxygen, choking, gagging, having any problems like that. So we're going to make sure that they are able to safely feed. And then they got to show us a couple other things. So stable weight gain. So they're continuing to gain weight. They're at or near their birth weight. And we can anticipate that they're going to keep going in that direction. And they're safely for discharge. And then pulse ox, so just SpO2. And this just means that they're able to maintain a safe oxygen level without any support. If they're going to need support, they're going to need a little bit more evaluation before we are allowed to send them home because they'll need some special equipment. And there are some things with the parents that we want to make sure that we can have in place to make sure we're a little bit more set up. So the parents, we got to make sure that they have caregivers in place, so in case that they need a sitter, somebody to help them. What's their support? We want to make sure they have the resources. So, do they need lactation support? Do they need help with food? Do they help with transportation? And then we just want to make sure that we develop with them a follow-up plan with the baby. So we want to make sure that after they are discharged, they're going to be meeting with their pediatrician, their primary care person, and that within a safe amount of time. So usually it's about a day. It may vary a little bit depending on appointment schedules and if you're discharged on a Saturday and the place isn't open on a Sunday, but you get the idea on that one. And then with the parents, if there's any special things that the baby needs to go on home with, we want to make sure that they're competent in whatever they happen to have. So even if they're not on any special care or anything like that, we want to make sure that they can do the basic care. They can change diapers, they can safely feed, and that through all this, they can provide what's called a safe environment. So the baby has a safe place to live, to thrive, to grow, and we're not going to have to worry about anything bad happening. And then we have our advanced care. So if the baby needs things like advanced feedings, oxygens, devices, there are a few things that we're going to have in place. Of course, we want to make sure that they have their basic care and safe environment in place over all of this, but then we need a couple other things. So one is going to be infant CPR. In the event that this needs to happen, you want to make sure they're able to do that. You want to know if there's some problems, when and where. Are they going to go to get help? So are they going to call a nurse line? Are they going to call the doctor's office? Do they just report to the ED? Just what they're going to do. If there's any special medications, or make sure they know how to prepare those medications to give to the baby. And if we have any special devices, so oxygen, ventilators, apnea monitors, anything like that, we want to make sure that they have the knowledge and ability to handle any type of those equipment that they may be needing. So on our other side, with discharge, we have a couple other things to talk about. We also do discharge screenings. So we'll just put discharge screenings. And these are things that the infant needs to have done before they can safely get out of the hospital. And we're going to break this into two groups. We have our routine things that all babies are going to be having done, and then we have some of the special ones in case there's something going on with that infant that needs a little bit more of an evaluation. So discard screenings, the routine ones, go up. We're going to say newborn screen. So this is something that they obtain from all babies. It's state-based. They do a routine panel. They take a little bit of blood, put it on a card, send it off to the state, and they're going to do routine panels for the common genetic disorders that are known in that state, that the people that are in charge of healthcare decided that's what needed to be screened for. It's not going to test all the special ones, but you'll get a couple of the basics down there. Next thing over here, we're going to do a hearing screen. I'm going to draw a little ear here to make us remember that. So they got to get their hearing screen done because we want to make sure that there's no problems there. And if they are going to have problems, that we're going to catch them here and be able to send them to a specialist earlier than later, because being caught early has better outcomes. So we're all for that. Then we have CCHD, or critical congenital heart defect. So we don't want these babies to go home, have a day or two pass, and all of a sudden when one of their shunts, a PDA, something like that, closes, they end up unable to oxygenate their blood and dying. So we want to make sure we're doing just the routine screenings for this. And usually they're just going to look at the pulse oxes between two sites, usually right extremity, the right arm because of the blood flow, which we'll talk about in the cardiac lectures, but the right arm and then a lower extremity, and see if there's a difference. If there's a big difference, then yeah, we'll make sure that they get a full workup and echo, all that stuff. And lastly, we want to make sure they get their Hep B. Of course, the parents have every the autonomy to decide that they do or do not want that vaccine. But it seems more popular now, or more common to run into parents that are saying they don't want the Hep B, but every knowledgeable medical group out there and around the world all recommend doing your hepatitis B. Okay, so special considerations. So we got a special baby, had some special problems, some special considerations going on with this baby. We're going to need to do a couple of things. So we want to make sure they have a head ultrasound before they go, because we want to make sure that they're not having any type of bleeding in their head, or if they are, that we're addressing that appropriately. We want to do a car seat challenge. So we're going to put them in a car seat. Ideally, you're going to put them in that car seat for as long as the drive that it will, in the amount of time it would take them to get home. So if you got a 30-minute drive home, you put in them for like 30, 45 minutes to make sure that, yeah, they can handle being in that car seat without having any drops in their oxygen, any obstructions to their airway, anything like that. And we're going to pay attention to them. If they don't pass that, we're going to wait a little bit longer. Sometimes there's some things they can do. Maybe they just repeat it. Maybe they talk to a specialist. There's a couple different things depending on how severe it was. Car seat up here. We'll make this line down here. We want to do an eye exam. Oops. Eye exam. So we'll draw our little bitty eye guy over here. So remember, it's an eyeball. So we're doing our eye exam, and then we have other vaccines that they might need, and this mainly is going to be RSV if it's season, and your flu also if it's in season. So if you're in that November to March-ish, it seems to have a little bit of wiggle on there. But about that time period, you want to make sure they're having that. That way we know if they're exposed to that, they'll hopefully either not get it as severely or hopefully prevent the infection. And then lastly, we want to make sure they have an appointment. And if they needed any follow-up diagnostic tests after they were discharged from the hospital and sent home, we want to make sure that those are scheduled. They know where they're going, who they're seeing, when they're going to be seen. And yeah, that's where we're going to go with that. Moving on. Next up, I'm going to try working on a little bit more typing because my writing is a little sloppy. I understand that. I'm working on it though. We're going to talk about here. Talk about some family-centered care. So we're going to drop this guy down here. It's connected because we want to make sure all of our discharge planning is family-centered, based on establishing this family, getting the family to grow and become a family. And this is going to require active participation from everyone. So we want to make sure everyone's participating. Sorry, it's hard to spell and talk at the same time. Active participation. And this is going to be on things like rounds, when they're coming around, seeing everybody for the day. This is also with the care, anything from routine care to anything specialized that might be for that baby. And this includes the rooming in that we talked about in that other lecture on family integration. So make sure that they're able to room in, and hopefully they are. It's perfect if you're going to discharge a baby. Some hospitals make it a requirement that the family spends a certain amount of time in the room taking care of the baby on their own with a nurse handy. So if they have questions, concerns, comments that they run into, they can say, oh, hey, I ran into this. Can you tell me what I'm supposed to do? And that way they're not going to be hit with that when they're at home by themselves. So we have to remember the next is our discharge planning. So the planning of all this is an ongoing process. So we are going to watch our planning's going on. We're participating in care, getting them to where they need to go so we can get them set up so they can safely go home. And then before we go home, we're going to take into consideration something called anticipatory guidance. With our anticipatory guidance, just the textbook definition, we're going to say it's in terms of discharge preparation and transition planning. It's about helping the family develop a realistic idea of what their life will be like with the infant. This includes the immediate future as well as over the course of their life. And we're going to develop a realistic understanding of how to care for their child. So we're going to make sure that they have a good idea about what to expect, what they should be doing, what to watch for, any concerns, where the baby should be at in terms of like developmental, neurological development. So good things that we're going to do with that. So just what to expect. So this is really that process of answering questions before they become questions. So with this, we're going to offer support and supplies if they need extra diapers, feedings, bottles, anything like that. We're going to make sure that we're promoting the bonding so they can do that. We have a safe environment, which is safety in general, and then anything with feeding. So if they need lactation support, if they need extra, whether it be women's services to get extra supplies for feeding, bottles, it may be the actual formula itself, and that is where we're going with this. So with our discharge, so all this, we're going to back out for a little bit, and we're going to make an overarching group. So we're going to say everything we got going on here, we want it to be communicated to whoever the infant's primary care team is going to be. It's primary care. So these are the people that once the baby's discharged are going to be taking over. They want to be taking care of these infants. They're going to make sure that they know their history. They get to know the baby, the family, the special concerns, anything like that. And they're in charge of the care after discharge from the hospital. So they're going to need a complete report. So we want to make sure at the hospital that they're writing everything down that happened. So a little line here. And that is going to be provided to them. So if they have questions about what happened in the hospital or anything like that, that they can have that answered. And this has an overreaching goal of being on that continuum. So they're going to discharge, they're going to take care of them, and we're going to provide education as well. This is education about any of these things that may be of a concern. Let's continue. That is where we're at with those guys. Now with primary care, we're going to drop down a little further. And we are going to talk about what we have for follow-up care. we're going to talk about what goes on actually with these infants. So these providers that are going to be doing the follow-up care are going to need a complete report about any specialty visits, any special ongoing problems, any screening results, any screening or tests that need to be done, what their vision and hearing tests looked like, any medications they're on or received, any specialist appointments or subspecialty appointments, and a couple things to consider with here. We're all little snowflakes and unique in our own way, but we have to remember, we have some overreaching themes and some things that are common with everything. We have to remember when it comes to these infants, none of them are the same. So we're going to draw a little family here. And remember that each family and infant is different. They have different concerns. They may have similar illnesses, treatments, therapies, anything like that. But when it comes down to it, they're unique, and we need to make sure we're addressing their unique needs as they come. Over here on this side, we're going to talk specifically about what the high-risk infant needs. So ones that were born premature, ones that were born and developed complications, they had some type of problems going on, they had to stay in the NICU at all. We're going to talk about some things that are going on with them on that side. Now, let me move this over a little bit because there is a lot that we're going to talk about on this side. But we'll start off, we talk about screens. So we mentioned them up there above. There are also what's going to go on for our screening with these infants. So quick and easy one is just head circumference. This is going to be at birth. We're going to get the baseline measurement, compare that to the chart, and figure out what it is. And then we're also going to get it at 1 and 2 years to follow growth. And that head circumference is going to give us a pretty good indication of brain development. Is their brain growing enough? Is it not growing enough? Is there some problems going on with it? So definitely pay attention to that. Next up is another easy one, is just the weight. So we get that weight and height. So we're going to get that at birth. We're also going to check it throughout the first year, monthly, and then yearly after that. That's how we're going to watch for that one. And then we got a couple other, these are the big guys that we're going to focus on for a lot of this stuff. So we're going to do hearing screening. I'm going to circle it because this is a big area. And we're going to talk about vision. And we're going to draw our eyeball. We're going to draw our ear up here, because these are some of the big areas that we want to pay attention to. So with hearing, let's talk over here. So we are screening to see if there's any hearing loss. So just hearing loss. And when it comes down to babies that are in the NICU, they have a pretty good chance of getting hearing loss. So some of the statistics out there are saying 1.5 to 2 per 1,000. So that is a big one, and we're going to add a little star there because that's an important one. Is that there are high rates of hearing loss among NICU graduates or babies that have been in the NICU. So let's talk more about these groups. So and there's an increase. We'll put it up here. Increased risk if you're preterm. And let's get into our types. So types of hearing loss then. So let's say, before we get into types, let's talk about how we screen. So this is a good one. So instead of types, we're going to jump right into the actual methods. So we have two ways that we're going to test. We have auditory brain stem response. This must be the A bar, ABR, however they want to say it. The next one is evoked autoacoustic emissions. Autoacoustic. And that's a lot to say, and it's just going to be the EOAE. All right, so we have those two tests there. And the difference between the two is important to remember as well. So with our auditory brainstem, they're going to put electrodes. If we can type today, we're going to put electrodes on the baby. We're going to check the auditory nerve. Which is cranial nerve 7. And we're going to see if there is conduction of a sound. And what they're going to do with the auditory one, it's a click. So they put little clicks through and then they measure if it's going through or not. And on the other side, we have a microphone. So the EOAE, we'll draw a microphone, or it looks like an ice cream cone or whatever. We'll put it to a box so we remember. So we have a microphone that gets probed that is inserted into the ear canal, and then they're going to check to see if you have a normal cochlear response or not. Now down here we have a couple things going on. So they're common. This one though, for babies in the NICU, it's common for these to have failed, and it's usually just gunk is what the hospital term is for that, but usually stuff like debris fluid, anything from the delivery that didn't get all the way out or anything like that. Auditory nerve is usually pretty straightforward though. Let's talk about what do you do though. So for babies in the NICU, I'm talking about NICU specific right now, there is an increased risk for false positives. So this is where the test indicates that they have something when in truth they actually don't. So if we have a failed screening, so they didn't pass their screening, we do a couple things. First up is just repeat at 1 month. And then depending on what happens then, we'll do a couple things. So it might be, if they had gunk and stuff in their ears, they grew up a little bit, we cleaned them out a little bit on their ears, they were able to pass the next time. So they were able to pass their test. We don't do anything. No follow-up, send them on their way, see you later. If we have a negative, we're going to send them off to a specialist, usually the audiologist. So they're going to go up there and see the audiologist. Now let's get more into what we talked about up here with our types. So these are the important ones. So we talked about how we're going to test it. So what are they actually say when they have a problem? So first one is conductive. So there is a transmission problem. So we're going to draw a little tower here with our signals getting sent out into outer space. And somehow they're not getting sent the cochlea. So for whatever reason, they're going this way and they can't get there. And this can be broken down a little further. So there's something blocking it. And there's the subtypes. And the first one that we're going to talk about is transient. So this is what we talked about a second ago, where we said the baby just has gunk in the ear. So debris or fluid might be another one that comes up that's just in there. we need to get that out of there, then they're able to pass that test. Next one is our permanent. So in our transient, we could fix it and things come out. But with this one, we have a true anatomic obstruction. And that is blocking the sound from reaching the ear, the cochlea, And yeah, that's our problems for that one. So conductive loss occurs when there's an interference in the transmission of sound from the external auditory canal to the inner ear. We have our permanent that occurs when there's an anatomic obstruction of the outer ear or the middle ear that blocks sound transmission. And transient that occurs when there's debris in the air canal or fluid in the middle ear and it just blocks the passage of sound waves. Okay, so that is our first one. Next up, we have sensorineural. Put that here. Okay, so sensorineural, this comes when there is a abnormal development or damage to the outer hair cells and the cochlear hair cells, or the cranial nerve 8 that impairs our sound conduction. So we are going to put our inner ear and our auditory nerve. Here, which we have as 8. We have some problems with our hair cells, the outer or the cochlear. Okay. So they're what we have. So if we do have, though, we can have one or the other, or we can have both. If we happen to have both, we simply call it mixed hearing loss. So that's when we have a combination of the two types. And yeah, that's what we're talking about that. Next up, we have one more. A little bit more room for it, which is your auditory dysynchrony. All right, auditory dysynchrony. They also call this auditory neuropathy, and this is about 10% of all infants with severe permanent hearing loss. So our outer hair cells are intact with this one, but the inner hair cells, the myelinated fibers, cranial nerve 8, the signals to the brain have responses that are dysynchronous. So it's not relayed in a consistent manner. So we have an outer ear that gets a green light because it looks good. And then we have an inner ear, however, that does not look good, doesn't check out, has some problems. This is also could be damage to cranial nerve 8. So we're going to be watching for that. So we have our transmission tower, and it's sending signals out, but they keep getting interrupted. So we have some problems with that sound getting there. So specifically with this one. This also includes things like hypoxia, as well as immune disorders. And 40%, let's put this up here, genetic. So we'll draw our little genetic guy here. It's a little messed up today, but that's what our next one's going on. So that's what we're looking for with those patients. Now, let's say we'll move this over here. Let's go with a lighter color. We're going to say, if we have this, is going to be zoom in, and we're going to talk about hearing loss. All right, so if they end up having hearing loss, there's a couple treatments that we're going to do. So up here, we can do hearing aids. The first one gets fitted about 1 month, but then you have to replace it every 6 to 8 months because the infant's going to grow and those are no longer going to fit or work. Another option is a cochlear implant. They can do this usually over 18 months. If it's really bad hearing loss, they can start usually at a year, but you're going to see this mainly over 18 months. This is a procedure, so it comes with a risk. Big one for that is just meningitis. And with that meningitis, the most common pathogen is our Streptococcus pneumoniae, so we're going to make sure they're having their vaccinations, and we're doing everything we can to take care of that. Now, that was a lot, but we're going to got a couple more to talk about. Let's move that back over. We have our vision, so a couple things with vision that we're going to talk about is, let's change to our red. So the vision screenings that we're doing in vision are going to come down to, let's call it your red light reflex. So we're going to be looking to see if we can see the refractory light when we are looking at their eyes. If they were preterm, we're going to follow up for ROP, retinopathy of prematurity, and we're going to say about 1,500 grams or less than 30 weeks. And we want to know when, so timing, when does this test need to be done in terms of follow-up. There's our little clock to remind us of timing. So the first one is going to be at 31 weeks post-menstrual age or 4 week of life, whichever ends up being first. We're going to make sure that that happens. Other ones, so who gets a follow-up? So other groups that we're going to see is if they have simply an eye disease, infections, like that, if they have any metabolic or genetic issues, make sure that's getting checked off, if they're preterm or extremely preterm, or if they just have a family history. We're going to make sure that we are checking out their eyes a little bit closer than just the routine screening. All right, thinking. All right, now we're going to get up to that high-risk infant that has a couple things specifically that we're concerned with them. Oops. So we're going to zoom in here. Now this one's not it can get a little confusing, but we're going to pay attention to this. So the high-risk infant has some definitely concerns because they are at risk for some things, mainly neurodevelopmental impairments. So neurodevelopmental impairments. You got a couple groups. So who's at risk? It's going to be those ones with choreo, abruption, tobacco use by the mom. You can just draw a little cigarette thing here. It's going to help us remember that tobacco is one of our problems, as with everything, or any other substance. So street drugs, things like that. Infants that are intrauterine growth restriction or IUGR. or the term infant, if they have things like pulmonary hypertension, if they required mechanical ventilation, if they ended up on ECMO, if they had an HIE, hypoxic ischemic event, and then if any gestation, if they developed any type of head problem, so if they had an IVH, if they had seizures, if they had BPD, which isn't a head thing, but a lung problem that can cause some problems up there. So that's what we're going to be watching for our high-risk groups. Now let's talk about with them. So we're going to do assessment of their neurosensory and their developmental assessment. So we're assessing them up there. So this is an ongoing process that we're going to watch them to a correct gestational age, whatever it may be, up until about 2 years. Sometimes they may wiggle higher, they may wiggle less. It just really depends on the infant because they're that individual and we're going to pay attention to them. So what are we looking for in our neuro? We're looking at a couple different things. So we have a neuro development delay. These are just the classifications. These are infants or end up being older children with an IQ less than 80. So these are pretty impaired individuals that we're going to be having in this group. And we have ones with a neuro abnormality or abnormal. So these are baby infants, patients that have any issues with tone, whether it be hyper, hypo, so increased, decreased tone, or things like CP. We have just our developmental delay, and this is on a spectrum of cognitive or cognition, motor, language, adaptive, or social, emotional. We have on that scale. Then we have what's called a global, which is a little further down of this other type. Global developmental delays, and this is they have greater or equal to 2 areas up here that are impaired. Okay, so that is in our neurodevelopmental. So we have to talk about our assessment skills or assessment. So when we do have these findings, it's really important to include our early interventions. So when we identify something that's going on, we get an early referral, and this is really what's going to be helping us in terms of our outcomes. So we get the problem addressed early, and these infants are able to get the special support that they need, and they can hopefully thrive and flourish. And with our follow-up, we've got one more group down here that we're going to talk about, which is important for these babies, any baby, but our specials. Special FU, so you know who you are. No, it's special follow-up care. So what are we going to be talking about here? Well, we talked about it, mentioned it a minute ago, but our vaccines. So mainly, again, our RSV and flu. And these are going to be given based on their chronological age, not their corrected age. So, how old are they actually? Are they 1 month? Let's say they're 25, born at 25 weeks, but they're 1 month old now. We'd say that they're 1 month. In the hospital, yeah, we'd consider them the corrected gestational age, but in this instance and with the vaccines, we're going by chronological age. And then the other big area for these kids are our growth and nutrition. So that's the important stuff. Making sure they have what they need to grow. So if we have a preterm infant, they could have some increased risks for delayed growth. With this, though, we can also have what's called ketchup, not what you put on your French fries, but basically it's a period of exaggerated growth after a period of delayed growth. So head circumference may continue to go up for 6 to 12 months of life during those first year. And while they're in this catch-up growth, though, we want to make sure that they're getting their special feeding. So increased calories, whatever it may be, because you don't grow if you don't got the nutrition there. And this might go on for about 6 to 9 months. And in terms of when we're checking at them, so what is actually bad growth or poor growth? Well, when we look at them, if we can plot them on our thing, and we say that they're whatever our growth scale we might be using, it depends if you're World Health or the other one, but less than the 10th percentile. Now we got to talk about some of our extra supplements we can be given. These are for a lot of them. So we have our iron and our vitamin D. So the vitamin D recommendation is 400 international units. And this usually, if they're on some type of fortified formula, they get it from there. With our iron, it's going to be anywhere from 2 to 4 milligrams per kilogram. Well, again, if they're on any type of this formula, it's going to cover a lot of this, but they might need a little bit of supplementation after about a month. So they might need some supplements to make sure they're hitting that daily total that we want them to get. Now, moving back up. So we're going to zoom out a little bit. I know this is a real big one. So with all of these things that are going on, everything here with these patients, we're looking specifically at one thing that's going to come up. Everyone wants to know, what are the outcomes? What do we want to know about these babies when they get a little bit bigger, when things happen? So we're going to group that down into a couple age groups and kind of go over what's going here. So infants, they end up getting a delay, or there's a higher risk for delay, and if they happen to have this delay, it increases the risk that it's going to carry over into school age. So if they've got a moderate to severe, it's going to go on to the school. I know there's two O's. It's going to carry over into the school age as a delay. If they're school age, which is next, so school, things that can go with them, they got a lot of problems. Mainly, we're going to group them into behavior problems. Behavior, but let's talk about our preterm infants. So if we're preterm, they have a higher risk of a couple complications, mainly tension and hyperactivity. Next up, we have about 1. We have a 2 here for emotional difficulties. And lastly, what we have here is called socialization issues. So playing with friends, playing on the playground, making friends, all those things can be problems for those patients. So with our attention, we come into a couple different things. Big things that ADHD, for preterm infants, those rates are about 20 to 30%, which are pretty high. There's also a big risk that they could end up autism or on the autistic spectrum. It's definitely things we're going to watch out for. And moving on to young adults. So they can have a lot of problems that continue to carry over. One of them is just poor academic achievement compared to their peers, or those that were born at full term. Abbreviate that there. And it can carry over all the way into their true adulthood. It can run into problems with what's called executive function. And with that executive function, it's just a collection of processes that are responsible for purposeful, goal-directed behaviors like planning, setting goals, initiating, using their problem-solving skills and strategies, monitoring their thoughts and behaviors. And deficits in this involve impairments in the response to inhibition and mental flexibility. So they just have a tough time dealing with a lot of those problems. And lastly, we're going to overuse this one and add one more kind of overreaching problem. I'm going to make it here and expand it up here, because this is what's going to go on and be the highly influential part. So chronic illnesses. An important statistic: infants born 23 to 27 weeks have a 7.5 times increased likelihood of having at least a moderate disability. So a pretty high risk for that. And these can include a couple things. Mainly, we have our CP, our blindness, and deafness. That's why we're going to be making sure we're screening early to intervene early and getting the interventions that we need. So zooming out, I know this is a big one. There's a lot to consider in this lecture. Got it all the way over there. I know it's a lot, but fortunately it's not a crazy area. A lot of it's pretty straightforward, but that's all I got. We'll get questions up for you soon, and then we'll see you later.